So hi everyone, and thank you everyone who is joining us for one of our final sessions today for VHCC. My name is DJ Dave and I'm a final medical student at Imperial College London, and I'll be moderating this session. I won't take up any more of your time, but thank you very much for joining us. So we have Mr. Simon Fleming here, who needs no introduction from anyone who has spent any time on Twitter, a man who you can't get enough of and cannot escape. And we have Dr. Joe Szram, who joined us earlier on to also discuss leadership during times of uncertainty, who's a respiratory physician here at Chelsea and Westminster and the Royal Brompton. So without further ado, I will let them introduce themselves and then we will get started.
First. Okay, so those of you who tuned into my earlier session will know I've got quite a long introduction, but I'm a respiratory consultant. I work in an occupational lung disease service, which is very niche. And so my Twitter handle is Lungs at Work. But since I started that job, I've acquired loads of other jobs to do with medical education and academia. So I'm an honorary clinical senior lecturer at Imperial College. I was director of medical education at my trust, the Royal Brompton. I decided to change into becoming a deputy dean, which I do in South London. I also recently became the chair of NACT UK, which is an association looking after and representing all of the DMEs across the whole UK. And I have a bunch of national roles through HE looking after postgraduate medical leadership development. So I'm the lead of the leadership leads, which is really quite a silly title. I'm also the clinical lead for physician specialty recruitment and the lead dean for the flexible portfolio training program, which the Royal College of Physicians look after, and it's a brilliant program I'd had the chance to do, which is where you spend 1 day a week for the whole of your higher training doing something else, such as medical education or research or informatics or something else I've forgotten, quality improvement, how could I forget? And then finally, I decided that that wasn't quite enough, and I was going to go for another job during lockdown. So I had an interview like this over a camera, and I'm next month starting as the Lineker Fellow for the Royal College of Physicians, which is a role in which I advocate and support the clinical college tutors and associate college tutors who are trainees, supporting education in all of the trusts in England and Wales that the Royal College looks after. And I will be quiet now so Simon can do the same.
The only thing worse than introducing yourself is having to write a bio, because then you have to do it in the third person. Like, Simon is a Leo and likes long walks on a beach. So my name's Simon Fleming. Starting from the top, I guess, I'm an orthopedic registrar in North East Thames, in the East End of London. When I'm not doing that, which is technically my actual job, I do some other stuff too. So if you don't know what the Academy of Medical Royal Colleges is, it's every president of every college or faculty in the UK, and they will sort of meet up and have a bit of a to-do and make decisions. And they have a trainee arm, which is exactly the same. So it's every president or leader of the trainee groups, and we have it to do, and we make decisions and write policy and so on. And I'm the vice chair of that organization. I am also currently not doing orthopedics because I'm doing my PhD in medical education. So I've taken time out of my training to do that research. I am a co-chair, so I help run, design, facilitate generally something called the International Conference in Residency Education, which is the biggest medical education conference in the world focused on trainee-centric med ed. I am an editor for a couple of journals, but I guess the ones that is probably the most fun is I am an associate editor with a kind of overview of social media for medical education and the clinical teacher. Do I do anything else? And I guess in my spare time, I do a little bit of culture change work and this sort of thing. So generally, I like to keep a little bit busy, which is fine because sleep is overrated.
It's not overrated. Sleep is a very important thing. You weren't in that webinar earlier. Sophie West, who is my buddy. important sleep is.
To be fair, this is entirely true. I've been working very hard to change my sleep patterns because before I took my time out of training, I used to just not sleep. And because I've been out of my orthopedic training and been doing my PhD in medical education, I suddenly found that in theory, I could sleep, but I had forgotten how. It just felt weird to me to go to bed before 3, and it felt weird to me to wake up after 6. And it probably took me a year to train myself to get back to eating, drinking, sleeping, resting, whatever, just because we come from that culture that, you know, Mike and the rest talk about, which is that wellness is some kind of weakness, whereas actually self-care is healthcare. But it just takes us a while to remind ourselves of that, which I don't think has anything necessarily to do with this workshop, but still.
Well, I don't know, we've started off quite well because I've just got a bonus point from Beth for advocating a healthy work-life balance, and I would agree with that. So that is probably a really good segue into medical education, which does provide the opportunity to you all to have a healthy work-life balance.
Just for people who are joining us who haven't yet started medical school, who are prospective medical students, or students who are at the beginning of medical school who don't know what medical education is, would you want to try to have a go at trying to explain what it is? Is medical education not just medical school, or what is it? What would you define med ed as being?
Well, it is medical school. It's also postgraduate. It's also, I'm still learning stuff. I learned some new stuff. In fact, if you ever look, see me glance anxiously that way, I'm in the middle of a chapter about what the World Trade Center did to firefighters' lungs. So maybe I don't have such a healthy work-life balance if I'm clearly working on 2 computers. However, what medical education is lifelong learning pertaining to being a doctor, which is really complicated because being a doctor is not just learning a bunch of stuff about science that allows you to pass an MCQ, is it? It's much more than that. Simon.
Well, I was going to say, and you kind of, it's as if we rehearsed this. You segued nicely into it. I think when people start to think about medical education, when they first get into it, it is curriculums and it is assessments and it is theory. Medical education is the means by which information is forced into your head. And that's not what it actually is, because the joy of medical education is, if you get it right, it is also how you change everything, anything. And when people want to criticize medical education, they say, you know, those who can do, those who can't teach, and those who can't teach do medical education. I prefer the Top Gun model, whereby it's only the best fighter pilots who get to come back and teach at Top Gun school. And actually, if you want to make a difference, if you want to change the way something's done, the way you start is by teaching people. Education is how you change minds. If you think about the narrative around women in medicine, and you really go back to where a lot of it started, it was medical schools taking women, encouraging all of those male, pale and stale people hundreds of years ago that women could be doctors and that women could do the same as. And that is education. More recently, if you, without humble bragging or virtue signaling, if you look at things like the Nightingale Hospital, one of the first things they did was set up a faculty, because they recognized that you can't have healthcare unless you have education. It doesn't work. It doesn't exist unless you have people to teach and empower and to enthuse, because there's some stuff with medicine that's just rubbish. And you still need someone to come out and go, I'm going to teach you the best thing about the Krebs cycle. It is so awesome. And you're going to go, is it really? But then 2 years later, someone's going to go, yeah, it's a problem with acetyl-CoA. And you're going to go, I remember that from that thing that person said that time. And for me, that's what med ed is. It's the ability to enthuse and empower and change things in a way that has huge, far-reaching implications if you get it right. That's my definition of meded.
I'm going to stretch your Top Gun and go female here. So my job is a bit like being McGonagall in Harry Potter, because like she's a teacher and, you know, she's a bit of an under character, but then she comes out and absolutely bombs it when the things are important.
She's nailed.
Exactly. Okay. So that is what medical education is, because she's also a brilliant wizard. She's not just a teacher, and she's a formidable leader. I'm not really very much like her because I can't do stern face very well, but you know, that's to me is what medical education is. I think the other thing I would say is it's not transmission, it's empowering people to learn what they want to learn around the framework that you have to have. You have to have a framework of how to think about stuff. They're all a bit different though. I'm sure Simon and I have completely different frameworks, particularly now. He's in one specialty and I'm in very much another one. He probably, if he thinks about firefighters in the World Trade Center, he's thinking about all their bone issues and things, whereas I'm obviously thinking about their lungs. But that doesn't mean that we didn't start off learning stuff that allows us to think through that. You know, that's the method of thinking about how you learn, and encouraging people to continue to do that and extend it. And in our leadership talk earlier, we were talking about the fact that actually in medicine, what we're trying to do is keep patients safe and make absolutely no mistakes. But in education, you get to make mistakes all the time, because if you do it wrong, you just do it again. You get another chance. It's okay. And that's why the Nightingale was good, because it had faculty and they kept learning, didn't they?
I was going to say, I think it might be my chance to challenge you. I'm doing a workshop in a week or two's time around the opposite. I think it's absolutely fine to fail throughout medicine. I think perfectionism is why we have burnout. I think perfectionism is why we have blame. I think it is impossible not to screw up as a doctor. And I think, again, the great thing about medical education is, so for those of you who are just coming into medicine or are thinking about it, the great thing about medical education, my point of view, N=1, is that medicine's dirty little secret is that it's a social science. Medics love to talk about numbers and data, and here's a graph that shows categorically this, that, and the other. Bollocks. The fact is, medicine is about people, and people make mistakes. And the great thing about medical education is we learn how people learn, and we learn how to teach. And part of that is normalizing making mistakes so that you can facilitate learning from them. Because that's how all the best other things in the world works. No one in the military or in aviation says, you can't make a mistake. They say, if mistakes are made, you've got to learn from them so that we don't make the same mistake again. And that's one of those great things, again, about medical education. And Joe did touch on it, which is because it takes from all these different branches of learning and thinking and, for want of a better word, philosophy, you find ways of thinking about things so that instead of going, oh, you know what, I screwed up, I'm a terrible person because all the best people never screw up. You go, oh, I screwed up. I should probably think about that, work out why, work out how, speak to someone about it, learn something from it. And medical education is at the forefront of that. About, you know, at medical school, I remember hating reflective practice. And for those who don't know what that is, that's where you basically think about what happened, you know, why should anyone care and what are you going to do about it? And now I realize I do it all the time. And it doesn't have to be a written essay entitled, Today I Screwed Up, and it can be as much as sitting down with Joe over a cup of coffee and going, can we talk about the day I've had? And that's medical education too. It's got, and this is what's fascinating, because every day is a learning day, right? Every day is a school day. And if you're involved in medical education, not only are you learning every day, but you get to impart some knowledge too. And it's a great two-way street that you don't often see in other bits of medicine, from my point of view anyway.
Very well said, Mr. Fleming. It reminds me, what you touched on at the beginning reminds me on a quote that I heard just a few weeks ago at another conference, which was that medicine is the most humane of the sciences and the most scientific of the humanities. So you
A nice quote.
That was a great quote. You mentioned towards the end about failure.
Can I talk about that? Now I'm back.
Yep, go for it.
So there's a really good paper in my journal. I forgot about journals because that's a hobby. That's not a job, Simon, is it? Like you do that for love, right? Or do we need to negotiate these terms? Are you getting something I'm not?
I mean, welcome to the gender pay gap. It is a job.
All right. So I just do it for love. Future Healthcare Journal, guys, put all your papers in there. Full of amazing trainee work. There's an escape room paper, most downloaded of that issue. There's loads of cool stuff in there. Anyway, but there's a great paper which is called Why It's Good to Fail. And this it's just a brilliant narrative of why failure is so good for you. Because that's how we learn. That's how children learn to walk. That's how all learning happens. So you absolutely have to fail. And what you don't want is the system to fail around the patient. So I can fail, but Simon's going to sort it out because he's going to go, Joe, what the hell are you doing? What is that? That is right, not left, etc. The platform Joy it's FHJ. I'll put a link in a minute when Simon's talking. So I think what's really important is that we acknowledge that we are fallible humans. It goes into the human factors stuff, which Simon and I both love as well, so we could witter on about that as well. But medical education and human factors are basically two sides of a coin, in my opinion. You can't do one without the other. And you can't actually be a good healthcare professional without a full understanding of both, in my opinion. I think they're probably more important than the Krebs cycle. Sorry, all you biochemistry nerds. I did actually do quite well in biochemistry, but I don't remember any of it anymore, apart from the lung stuff. I'm quite good at lungs, but that's about it. Do you have a sensible point now to make? Because I've gone into, Krebs cycle.
So if I think about why I got into MedEd in the very, 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 very early days, it was like a two-pronged thing. So back in my day, when I was at medical school, there was nothing like what we have now, which is a lot of stuff called near-to-peer educating, where medical students teach other medical students. That didn't exist when I was a medical student. Hierarchy was even more hierarchical, as was patriarchy and everything else. And the theory was that if you weren't a professor, you didn't teach. However, because I went to a small medical school, there was a lot of kind of cross-pollination between the first years and the second years and the third years and the fourth years. There was still sort of a culture of people teaching one another. And because I love the sound of my own voice, I obviously got involved with that. And what I realized was teaching motivated me to work. I realized I couldn't teach cardiovascular exam to the first years unless I knew cardiovascular exam. So I had to learn it, and I had to learn it well enough that I could look confident with it. So I couldn't be, thinking. I had to be like, right, and from the end of the bed, we're looking for this. These are the 5 causes of clubbing in the fingernails and blah, 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 blah. And so it forced me to learn so that I could be an effective teacher, because I wanted to be the kind of teacher I always wanted, which were the ones that didn't rely on reading their PowerPoints and didn't rely on just basically making the classroom do all the work, but just knew their stuff so that it felt like a conversation, like a chat, like a story. And similarly, I am a surgeon, so I'm an ego-powered human. I hated being asked questions I didn't know the answer to. It made me feel really crappy about myself, which again is ironic because as I've grown as a teacher, I've learned that that's great. Having someone know more than you or point out a gap in your knowledge is awesome because you go, I have no idea. What a great question. But at the time I was 19 and I was like, no, I have to know the answers to everything. So again, it motivated me to work so that I could teach. And it's only as I've gone on that I've, again, learned what I'm good at, what I'm bad at, what I enjoy to teach, what I don't enjoy teaching. But for me, I first got into MedEd because it actually motivated me to be a better learner and a better student. And it was that whole thing of, to teach first, you have to learn and all that sort of stuff. Like, you can't just be a teacher. You have to go away and do the work and not just know the facts, but again, sort of know how to teach. Because the biggest mistake I think people make is they think that knowing stuff equals being a good teacher. There's that thing about knowledge is knowing that a tomato is a fruit, but wisdom is not putting it in a fruit salad. Just because you know tons doesn't mean you're a good teacher. And so what I recognized is not only did I have to go away and read all the clinical skills books and all the rest, but I then had to go away and learn how to impart that knowledge. So I wasn't just another guy reading a book at people. Joe, why did you get into education? Why do you teach?
Oh, my whole family are teachers. I was a rebel and went to medical school. I'm the only doctor in the family. Literally everyone in my family is a teacher or a head teacher or something. So it's just you grow up with it, and I was like, well, I'm a doctor now what? In seriousness, I think I probably started teaching in earnest during my research time. So I was out of program doing clinical work, kind of epidemiological research. And there's always slack times when you're waiting for ethics to come or whatever. And I was not one for sitting in my room and writing articles about stuff. So I found some undergraduate teaching to do and really enjoyed doing that, and got very involved in the design as well as just, it's not just delivery, is it? That's the thing, it's the design and thinking about how to make it a really engaging process, and then wanting to know more about the underpinning theory of how adults learn. It's totally different to kids, but sort of not different. And debating that, and you do discover this kind of secret social science of medical education, and then you discover all of medicine's actually social science, and they've been lying to you about the need for chemistry for all those years. And so I just carried on doing that, and I've been teaching about occupational lung disease for so long now. It's like 15 years. So, but I change it up every time because it's boring delivering the same stuff, and I find a different way to do it. Actually doing it like this virtually, we did a regional training day recently, and we completely changed the way we did it, because you can't sit in front of a screen for an entire day, you don't get the coffee break chats, all that stuff. We thought about that, and we had so many great messages back saying, actually, I was at home with the kids and I could still watch, and then I could go back because we recorded it, or I was on call, so I missed bits, but I came back in, and so on. And we did a bit of this where my colleagues and I, the three of us, just sat there and talked about all the difficult patients that we've looked after, and how actually just because that's all we do all the time and it's our specialist field doesn't mean we always know the answer. And actually the three heads together is what we need to be able to make diagnoses sometimes. So actually being very visible in how you practice medicine is probably the best way you can teach without any qualification. And if you watch really good clinicians that are in theatre or on the wards or in clinic, they will talk you through their decision making that goes on in here and why they exclude things and why they go a particular way. Because if you don't do that, then people don't understand the reasoning. They just have to follow a particular, pathway. And I think that if you're able to do that, you're going to be a great teacher, and anyone can actually do that. You just have to be open enough to do so and acknowledge the fact that you sometimes get it wrong and your trainee might get it right. And that's okay. In fact, I love that. It's brilliant when someone thinks something I haven't. Makes me
and it's fascinating you touch on the COVID thing, because COVID's completely changed medical education. It has made knowledge more equitable. There are 50 people in this room at the moment. If we were charging 250 quid a head for this talk and it was in Dublin, would all 50 of them been able to afford the ticket and the travel and the hotel and no, of course not. And if they were doctors, would they been able to get the leave and the time off? And if they were parents, would they been able to get the childminder and suddenly you can access all this stuff and, still be in your pants. The challenge is now going to be, why do we need conferences? What face-to-face conferences? What are the value add that they're going to give? And I think part of that, again, comes back to the social science of it, which is the human interaction, which I think this sort of system doesn't quite offer. So if I think about, what's a good example? There's a syndrome, those of you who aren't doctors yet, called DKA, which is something that diabetics get. And I remember that I learned to understand DKA in the pub when an older medical student went, well, it's really easy. D stands for diabetes, so give them insulin. K stands for potassium, so they need that. And A is acid, so you dilute that with fluids. And I remember being like, but that wasn't something that was delivered in a conference or in a classroom. It was that little personal interaction that you might have in a coffee queue or in at lunch or something, that I think is the thing that kind of Joe was talking about that continuous education. You've got people like us who have like the label that says teacher, and then you've got people who just teach during the day by continuously talking through their thoughts and their process, and they don't make you feel small. It's not a patronizing process. It's not like, a non-stop narrative of showing off. It's a non-stop narrative of, and I think it might be this, but I'm going to get a CT scan. I'll tell you why I'm going to get a CT scan, because of this and that and the other. I just saw a question about AFPs. Yeah, they didn't exist when I was a lad either. And this is the great thing about, again, MedEd. So when I was a lad, there were no AFPs. So these are academic foundation programs where you basically come out of medical school straight into a slightly sciencier job, academically speaking. You couldn't intercalate in medical education at medical school. That didn't exist. All these things have come about. And again, it's that great thing about medical education is that's been driven not just by people like me who are, old and grumpy, but they've been driven by medical students and by foundation doctors who've gone, we want to do this. And they come to someone like me or someone like Joe and they go, how do I do that? How do I set up a clinical teaching fellow job? How do I do research into this? And you go, well, that doesn't exist, but that sounds like a really good idea. I think we could learn loads from that. And so a lot of the opportunities that exist now didn't exist previously. And the great thing about medical education, if you're into that, is it won't be the same in a year's time. You will never be like same old, because the reason Joe and I meet in meetings all the time is because there's always something new. There's always the next thing, the next curriculum, the next assessment, the next theory, the next whatever. That means you'll never be able to go, this is what I do, it's the only way I do it, the end, la 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 la, because it's always changing as medicine changes, and also as people and society changes, and the way people behave and think and all that sort of stuff. So medical education has to adapt, because otherwise you're not ready to treat the people you're meant to be treating, because the world has moved around you.
The fascinating thing about education, as you said really much earlier, Simon, about everyone thinks about curriculum, is the curriculum's the last bit that catches up with everything else. By the time the curriculum's there, we've already moved on to something else that we're doing. So, of course it's important. There's a core bunch of knowledge you need for a specialty. There's no argument about that. But actually, it's really important that we as educators continue focusing on innovation in education in order to drive forward the clinical practice, and the two go hand in hand.
Yeah. It's fascinating you. Oh, sorry.
Sorry, Joe, one of the questions that we received is about the PG cert. So, Simon, you mentioned about the AFP programs, but one of the questions that people had is whether you would recommend doing the PG cert and how that fits into training.
Oh, there are so many PG certs out there, and you could do it any old time. Of course, it's good, because what it does is it forces you to learn stuff that you would otherwise just kind of skim around and read what you wanted, but not everything. It makes you write about it. As Simon said, if you start having to write about stuff, you have to understand it. I certainly understand more about the World Trade Center than I did when I started writing this chapter about it, because you have to go and read around it all. So it's the same principle. And you get a community of practice, which educators love. So you get some people to bash your ideas around. So, a bit like Simon and I are doing now, you go in and you go, well, I think simulation's a load of rubbish, and why are we even doing it? And then, someone there will say, well, actually, I think it's the best thing ever, and everyone should, live in a virtual reality at all times in order to train to be a better doctor. And you can obviously every opinion within those two extremes. And then you think, you learn to think differently about all sorts of things, and you get new ideas. So I think a PG cert is definitely worth it. I think, as in worth doing. I'm not going to get into the money stuff. I mean, I was really lucky, because if you're at Imperial, they will, and you're doing lots of education, they will put you onto the PG cert program, because they want more educators. It helps them with their medical school, and a lot of other medical schools will do that for you. So I didn't actually have to pay for mine. And so you may choose to do it a bit later when that opportunity is available to you, rather than stumping up money. And they can be quite costly, and I think that is a shame. It's much better when you're doing it as part of a community and an organisation, as I did. I think I I was at Imperial College, and it's for everyone. So I was with like astrophysicists and geoscientists, and everyone presenting their teaching projects. I was like, oh my gosh, I've learned so much, and I'm not sure it's even about education. So, you know, there are lots of ways of doing it.
Do you think everyone could do a PG cert, Simon? I mean, I know that a couple of points.
For those of you who've never sat a multiple choice exam, anytime that there's an option that says no one or everyone, it's probably wrong, because the world doesn't exist in absolutes. So the answer is no. I'm like Joe. I did my certificate, so I took a year out between core and I took a couple of years out because I'm in no hurry. I took a year out after core to be a teaching fellow. And I came back to Barts in London. I taught anatomy and clinical skills. And during that year, I was funded to do this certificate. And like Joe, it was amazing because it was the first time I'd been taught or had done any learning in people who weren't medics. I use this term non-pejoratively because my girlfriend came up with it, but it was a room full of muggles, right? She literally refers to herself as a muggle because all of us medics think we're wizards. But it was great because you know, we had educators from, say, English and history talking about having to go at the pace of the slowest person in the room. And then you had some of the medical educators in the room going, well, that's not acceptable. If you can't keep up, then maybe you need to fail. And we had this whole debate about, you know, that sort of thing. And it was great because there were so many different opinions in that room that I'd never heard of. I'd never even contemplated. But I absolutely agree as well that there's something about if you have the opportunity to do that kind of qualification while in a teaching environment, it's very different to, say, distance learning. Now, that's not to say that the distance learning version isn't great, and it is. And I used to do some work for Dundee University, who do a great med ed degree. But it's different because it becomes that dry, abstract thing rather than every day you're talking about teaching, learning, assessment, curriculum designs, communities of practice, theory, quantitative versus qualitative, all that stuff is very different to you get an email saying, please write an essay around the role of simulation versus having an argument with Shafi Ahmed, who's on one of the other channels, who is an evangelist of sim. And you can go, well, Shafi, I think it's all rubbish. Discuss. Show me your evidence. Show me why it's the panacea. I agree with Joe entirely. Do the PG cert when it suits you, though. Like when it feels right and when you feel ready for it. The money thing is a ball ache. There's nothing to be done about that. It is one of the many inequalities in education is that certain things cost money that they probably shouldn't, because by definition, if you can't afford it, then you can't do it. But again, there are ways around it. You know, if you start your foundation year one job and you don't want to start, say, revising for a postgraduate exam or whatever, do it in your F1. Equally, if you want to get your exams out the way and you have a plan to take a year out and be a teaching fellow, well, that's the perfect time to do it. Like, why wouldn't you do it then? And it's the same with, to be fair, masters, PhDs, whatever. The joy of med-ed is it doesn't stop existing just because you're not doing it. So when you're ready, it'll still be there. And you can, the more you immerse yourself in that world through conferences, through social media, the more you'll get a feel for what you want to do and how you want to do it. So I hold my hands up and say that I put the first 2 years of my PhD in the bin. It turned out my research question was no good. My method, I'd just gotten it wrong. And it was only through multiple interaction with multiple people that I came to realize that. And I'm so grateful for it, much as there was a certain amount of like, God damn it, at the time. It meant I didn't waste my time doing rubbish work. Instead, I'm now studying something that I care about in a way that I care about, which means by definition, I'm better at it.
Thank you, Simon. So just moving on to questions, another question that we've had is, what's the most innovative teaching session you've ever done in your experiences?
I've been typing. I have been listening, Simon. You know I do both things at the same time quite regularly. So I was just coming up with some of the stuff I used to do when I was bored of undergraduate PowerPoint. And it's occupational lung disease. So it's not a particularly massive part of the curriculum and you get half a day. So you can basically do what you want as long as at the end of it, You guys know the answer is occupational asthma. So I spent loads of time working on things like, I did this whole scenario of an outbreak of disease in a workplace, and they had to work out who the culprit was and how they were going to persuade the board to change all their strategy around it. So it took 3 hours for them to do. And we got all these big scary people in to sort of stare at them while they presented, which was quite fun. And then I brought a load of patients in and put them all in groups with a patient in each one, and then gave the patient a scenario to work on as a clinician and with all the students. So the patient knows all about their disease because they have it. And then the students know about medicine, but they don't really know much about occupational lung disease yet. So they were all sitting there trying to work out what the answer was. And then obviously what you do is then you flip it, and at the end you say, right, okay, that's great. You actually went completely wrong, but don't worry about it because the answer is this, you will pass your exam. But actually they learn so much more, and also about the interaction with patients and how disease affects them. You know, that whole issue of their own experience is so important for people to learn, because otherwise it's, you know, it's just a disease, and you don't meet these people for whom it's a massive deal to get something. And it will affect people very differently, and that experience is really important. And I think undersold actually in undergraduate curricula. The more patient experience is definitely needed. So those are some examples, but I mean, I could give you loads because I'm always doing really daft stuff in the name of education.
Yeah, I mean, I was thinking about this. My favorite one probably. So one of my great passions in the literature, it's called being a disruptor. In real life, it's called stirring shit up. And so I was asked to give a teaching session to the great and the good of a very eminent Royal College. And I was asked to get them thinking about culture change. So I based it on the university drinking game, Never Have I Ever. And about a week before, I got a very stern letter saying I wasn't allowed to make senior college leadership drink. So instead, what I did was I came up with, the game was called Never Have I Ever Been a Bad Trainer. And instead of drinking, if they had done the thing, they had to put a sad face sticker on their face. And then, a bit like at medical school, we had this rule called Jackanory. So if you were the only person who'd done it, you had to tell a story. So I introduced this rule. So if you were the only person who put a sticker on your face, you had to stand up and share your experience. And we created, like, it sounds wishy-washy, but it was important. We created a psychologically safe environment where people were willing to share stories of when they'd screwed up at work as a boss, as a trainer. And all of my questions were undeniably, unashamedly prompts for quite difficult conversations. So, you know, one of them was like, never have I ever called someone an inappropriate term of endearment at work. And so, of course, before anyone put stickers on their face, they put their hands up and they're like, well, what, define inappropriate? And I'm like, no, you define inappropriate. Well, and so we started off with, is first names okay? And then mate, and then darling. And then what about regional variations? If you're some parts of the country, love is a gender neutral term that you call everyone. And then we had someone saying, well, what if you've been friends with them for ages and they've got a nickname? And it was a whole thing based on never have I ever. But actually, it worked really well because it was so informal and jokey that they didn't realize they were admitting to hierarchy, patriarchy, bullying. And it was only at the end of each thing that people would go, oh. Like there was a professor who said, well, I'm a professor of so-and-so, and I would expect you to call me Professor so-and-so at all times. And I said, okay, fine, absolutely. I'm your trainee and I demand you call me Mr. Fleming at all times. And he goes, well, I would think you're a pompous twat. And I was like, well, I mean, am I the only one who sees the irony there? And like the whole room kind of applauded a little bit. But then fascinatingly, right, we talk about failing at the end of it. And this is one of the big turning points in my career, actually. At the end of it, a lady came up to me and she said, you're in trouble. And I was like, am I? And she was like, yeah, this whole workshop was about white male privilege. And I was like, is it? And she said, yeah. So you, white guy, are going to tell all of us that we're going to be on first name terms. And I said, yeah, flattening the hierarchy is great, right? And she said, yeah, but I am the first person of color and I identify as queer in my family to get a professorial chair. And you suddenly tell me, Mr. White Guy, that I'm not allowed to call myself a prof anymore. How dare you? And I was like, And she was like, have you ever been mistaken for a nurse? I bet you haven't. So of course you don't mind if we don't have to call you doctor. And I had to go away and reflect on the nuance of that work, because at the time I thought I was onto a winner. And actually that workshop, I probably learned a lot more than a lot of the people in the room, because, you know, she wasn't angry about it. She kind of just reflected it back to me, and I had to go away and completely reassess the way I challenge things like hierarchy and patriarchy and blah, 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 because I'm a straight white guy. So it's easier for me to do. But yeah, that was probably the most innovative teaching session I've given. But again, like Joe, I've done loads of weird and wonderful things depending on the group and the target and what you want to teach, and you have to be mindful of that stuff. It's tricky. I used to do a lot of walking meetings, and then one of my colleagues pointed out to me that it was overtly ableist, and I was like, oh yeah, that's a thing. I probably need to look into that.
Cool. So thank you, Simon, for bringing up the topic of introducing drinking games to MedEd and how it ties in with innovation. Just along that same theme of research and MedEd, do you think research and MedEd both go hand in hand? I mean, they're often separated out as different parts of portfolio development. So you have MedEd, you have research, and then you have leadership. Or do you see them as both sides of the same coin?
I think we're one person, so that's the same as saying, are you a doctor or are you a parent? It's like, well, I'm both, aren't I? Especially at the moment. I think they're all right. So I think they're all intertwined. I think the freedom that having an academic post gives you is to be able to do education as well. So most academics will do education. And actually, if you talk to medical school leaders, they will tell you that it's not the research doesn't make the money anymore. It's the paying punters in medical school. So actually they are cottoning on to the fact that they need good educators, because students will go, I mean, you know, name will get you a long way, right? So Imperial College isn't suddenly going to disappear because, you know, a load of people are rubbish teachers, but eventually over time, you know, reputations around teaching will matter. And it's really interesting. So when I sit in my dean role and we look at what medical schools submit, you know, if they want extra places or, you know, they want to expand stuff, and you can really see where people are thinking about their students and the experience that they're going to get and thinking ahead for them, not just, oh, they'll like medical school. They are doing you all some favors in making you ready to be a doctor as well. And that isn't, you know, we talked about learning, that you learn through failure and you learn through discomfort. So actually being a medical student isn't a comfortable place. You know, there are moments of amazing euphoria and excitement, but there's a load of rubbish that goes on in there, but you learn a lot more from that. And if you talk to people like Simon and I, we will tell you all the times where we had total disasters during medical school. And you know, those ones I remember probably more, you know, apart from when I passed my exams, hooray, we were happy. But you know, that you really remember when things didn't go how you expected and what you learned from that. So I think it's a really complex paradigm trying to balance academia, MedEd, do your actual clinical job, and then doing some leadership, and something has to give. So I don't do a lot of academic work. I write the odd thing, and I work with, you know, I sort of collaborate with people who mainly do research. So at some point you have to decide what you're going to do, but not just one thing. I mean, I'm going for 3 at the moment. 3 kids, 3 jobs. I think it's okay. We'll see. Watch this space.
I've got no kids yet, which is probably why I've got about 1 million more things on my plate. I'm very aware that they will reduce as the ratio shifts. I mean, if you look at, I agree with Joe. I think it's a spectrum. So you can be a clinician, you can be a clinician educator, you can be a clinician researcher, and then it's just about, if you imagine that they're not black and white things, it's about how much of those boxes you shade into, because you cannot be writing 50 papers a year if you're also running a clinical practice and also lecturing twice a week. Can't be done. Not possible. Just isn't a thing. And the trick is to find the balance of your... So I don't use work-life balance anymore. I talk about work-life integration, because I've realized that there's no point in my life anymore where one stops and the other starts. I've accepted that. So it's about where you find that kind of homeostatic mechanism that means you go, you know what, I think I'd like to do more sciencey stuff because it allows me more freedom to plan my time, which means actually I can take care of my well-being a bit more. I can give myself Friday mornings off because I need that, or I'll go bonkers. Versus, you know what, my passion lies? My passion lies in teaching in the operating theatre. That's what I love to do. So you know what? You need to be in the operating theatre more. And finding that balance is different for each individual person. And the UK is, I would humbly suggest, a little behind some other countries in the professionalization of trainers, which means that in hospitals, it's very hard for a lot of people to have the power to make that call. Whereas, for example, in general practice, if you identify as a trainer, you get that system which supports you. Saying that, we're moving on, and actually it's the Royal College of Physicians in particular that are very much pushing that agenda of it is okay to want to do more than one thing, and it is okay to not. There is no shame attached in going, you know what, I don't want to be a clinical doctor every day. Some days I want to do something else, and if that's teaching, then that's mega, because you're out of your day-to-day, but you haven't left your world entirely. It's not like you're like, and on Fridays I use a loom, though of course you can. So I think that research med-ed balance is a very personal choice. Again, to say everyone should have to do research is by definition a flawed theory, because if you make everyone do research, you'll get a lot of really bad research. Just like if you make everyone teach, you'll get a lot of people who are terrible teachers, who don't want to be teachers, teaching badly. And we're getting better at recognizing that actually that's probably the way it should be. Whereas the old medical system was apprenticeship model, right? So by definition, everyone gets to be a teacher because everyone's a master. And you're like, no, I don't think that quite holds water anymore. And we're starting to recognize that the best teachers are people who want to be teachers, are passionate about it, and have gone out their way to get good at it, rather than just, well, I finished my training, so I guess I'm a teacher now. And there are other countries and certain specialties which are getting that balance a little bit better. And interestingly, I feel like I've gotten Jo's attention because I'm not sure if she agrees with me or not. I don't know.
I was just reflecting on what you said about research. So it depends what you define as research. So my research consisted of phoning up a bunch of GP practices and persuading them to participate in working out whether people had occupational asthma or not, and then talking to some patients. And then, you know, that's a publication and that's a paper and that's research. But it's not research as in like a bench and a molecule. And it's not research like physiology and, you know, doing weird imaging or catheters or I didn't really have to go very near a p-value, although I did learn some stats because I was quite interested in populations, and that's quite interesting. So I learned all about John Snow and the water pipe and cholera. And then, of course, I walk in on my daughter's teens class a few weeks ago, and what's she learning about? Bloody year 8, John Snow and cholera. And I'm like, tell me it's the water pipe. So she got a good star for that one. So research means different things to different people, but I think the question really is academia and med-ed, and academia is a little bit different, isn't it? Because actually you can be a complete academic just doing med-ed, and you will write about med-ed probably, but you don't actually have to. I mean, if you look at the people who are in senior educational leadership roles in this country, a lot of them haven't published about education, loads of them actually, because actually what it is organisational leadership, and that's slightly different. So you know, my role as dean, I don't teach anyone, do I? But what I do make sure is that people are getting the training and teaching that they need. And I know how to spot it because I've done it. So there's something around that, I think. I'm just thinking about it. You've made me think as usual, Simon.
So
yeah, see, disruptor.
We're just coming up to the last few minutes of this session. And thank you both of you, Jo and Simon, for sharing on your experiences of med-ed and also small tidbits and stories from both of your careers. For those of us who are starting out, so those of us who are prospective medical students at the beginning of our careers, medical students coming towards the end of our time in medical school and looking forwards looking forwards to being junior doctors, who have developed an interest in med ed, how would you recommend that we go about fostering that interest? Is it just a matter of trying to teach wherever and whenever? Is it a matter of pursuing the PG certs that was mentioned slightly earlier, doing an AFP, or what would you guys recommend?
I would go for a few things. I think teach each other, because if you can explain it to someone else, then you know it. So it's good for you too. So study groups are where you actually learn to teach. I think about teaching what you learn to A-level students and school kids, because actually if they understand, if you can communicate to them what you've learned, and you should be able to, then you'll be good at teaching and you'll learn your stuff. So it's basically revision for you. So it's a win-win. So teach people that it's appropriate to teach. And then as you go along, just volunteer to do more, because people always want more people to teach. There's absolutely no way. Like if one person says no to you, they've either like not listened, they're very strange. But, you know, in any case, just find someone else, because it won't take too long. It's much easier to get into than into research, which can be really tricky. Actually, I really struggled, and I basically forced myself into working in the tertiary hospital just so I could doorstep all the professors to do my research. Whereas in education, people are very much, yeah, come along, and I'm sure we can, you know, get you involved and so on. So it's really about having that confidence to offer. And if you're brave enough, then you will find some people that you want to work with. And, you know, do shop around a little. You won't, you know, you're not going at your stage to know that you want to be doing occupational lung disease. I certainly didn't. I was going to be a neurologist. I know, a radiologist at one point. Gosh, I've had about 4 career decisions along the way. So I think, you know, don't get too fixed in a particular ology or branch of medicine. Just do some teaching with some people that you seem to like, and that will make you more comfortable and more confident in doing so.
Yeah, no, I think Joe said it all. You give it a go. Don't be afraid to cock up. And the best thing about medical education is it's a self-selecting group. So we're a reasonably nice bunch. So you will be surprised that when you approach med ed people, rather than biting your head off or saying, well, actually, it's milk and 2 sugars, they'll be like, great, let me buy you a coffee. Let's have a chat. How can I help? Because the kind of people who are involved in med ed are those kind of people. And so if you literally just come up to one of us and go, I think I might like med ed, we'll be like, well, good. I will now buy you lunch and tell you why it's the best thing ever.
Cool, everyone. That was Simon's invitation to stop in and speak to him about med ed if you'd like a free lunch. So that sort of brings our session to a close. I think with all the Harry Potter references, I think we have demonstrated that med ed is indeed magical. So everyone, feel free to develop your interests. Feel free to give both Joe and Simon a follow on Twitter. They share some very, very interesting and quite funny things. And thank you everyone for joining us today on Current for Hub. It's been a pleasure being your moderator, and I look forward to seeing you all soon. And thank you once again, Joe and Simon.